Hello, hey, it's Dr. Scot Hutchison here in Tucson. Thanks for tuning in to Hutchison's Huddle this week. And today it's about recurrent pregnancy loss. And this is a very, very difficult topic for many people. It's miscarriages are always a really rough deal, and certainly the most most people will kind of perceive a miscarriage as sort of like a death in the family. Even some very early ones can be very problematic for folks. So and part of it is, I think, that there is very little discussion. I mean, you're not going to go broadcast this to the world, but of course, this has been a very disappointing episode for you as a patient if you really had desired a pregnancy. So a lot of questions we've gotten over time about miscarriages. How common is miscarriage? Well, miscarriage rates kind of depend on how old you are, but as many as 50% of pregnancies are miscarried. There have been some studies looking at women who are in their 20s, looking at pregnancy tests, serum blood pregnancy tests that are drawn a day or two before they get their period, and really up to close to half of these women are getting pregnant, but only about 20% of them will actually go on and have a baby. And that's in the early 20s. So humans have a lot of miscarriages. We define recurrent pregnancy loss or recurrent miscarriage as 3 miscarriages or three pregnancy losses under 20 weeks of gestation, or even now, some people will say, even if you have 1 over 10 weeks of gestation where you saw cardiac motion or heartbeat on the ultrasound, that will qualify for further evaluation to look for causes of recurrent miscarriage. So let's kind of break those potential causes down. So we know that genetic components within the embryo itself are responsible for about 70% of those miscarriages. Humans have a lot of genetic material, and a lot of it doesn't match up very well once the embryo is created, whether it's in the body, in the fallopian tube, or whether it's in the laboratory. So, and we see lots of abnormal embryos, even with donor egg embryos, and these are young women in their early 20s who, by and large, have nothing wrong with them or nothing we can determine. And so they're kind of felt to be like the controls for humans as far as fertility. And we'll have, embryos created with donor eggs and donor sperm from a sperm donor even under age 30, and we will get abnormal embryos from those as well. So humans just have a lot of abnormal embryos. So when we try to look at beyond just those genetic factors, and certainly those genetic factors as you age tend to get worse. So miscarriage rates in the 20s, for example, are probably around 12%, 15%. Then by the time you get into the 30s, later 30s, they're certainly climbing up into the 18 to 20% range. And then by the time you hit age 40, then it's much more like 34%. By 42, it's about 50%, and it just keeps going up from there. So I guess the interesting thing is that with a lot of those miscarriages, the embryos are so genetically abnormal that they are non-compatible with life. So many of those embryos that we see in the laboratory that are created have multiple things wrong, and not just one genetic factor, but many. And when we talk about being able to look at the genetics of embryos, you're not looking at very, very small gene deletions. You're looking at the packets of DNA that you can visibly see with high magnification when cells are dividing, and those are called chromosomes. And humans, we have 23 pairs of them, or 46 chromosomes. And males have an X chromosome and a Y chromosome. Females have 2 X chromosomes. So all of the chromosomes basically are kind of X-shaped. You can kind of Google this as I talk here. And when you get these chromosomes, the half from your mother, half from your father, then they cross over, and there's a lot of jumbling up of DNA. And that's why the same two parents can have several children that all look different. We all are a little bit different because of that crossover and that of sharing of or of mixing up of genetic material. But a lot of the time that just doesn't go right. And you'll have duplication of chromosomes, so that there are 3 chromosomes in there instead of just 2. There's just be 2 of each one. And then sometimes you'll have situation where you have 3 chromosomes of every chromosome, and so those just aren't going to turn into good embryos and go forward. So out of those, those genetic embryos, genetically abnormal ones, you can also have embryos that have what's called a balanced translocation. And a balanced translocation is where you as the individual, you have all of the genetic material you need to function, but part of like one chromosome may be hooked onto another. And that's fine for you, but when the chromosomes need to divide and those eggs and sperm need to be formed, then you may have too much of one set of genetic material or too little. And then that can lead to at least about a 50% risk of miscarriage if you have that what's called balanced translocation. Some balanced translocations never result in live births, so we always send those folks to genetic counselors for further evaluation, because the genetic counselors will keep track of the different kinds of balanced translocations, and they will tell us what the probability based on other people's experiences with that same translocation are, as far as what they can expect their risk of having more miscarriages will be. But in general, it's about 50% for most of those. So we look at those genetic factors. We also look at uterine factors. So there can be factors in the uterus that can cause miscarriages. Certainly the class of birth defects, which are called uterine anomalies, those can often cause people trouble. There are many types of uterine anomalies, from failure of fusion of the paired ducts that form the uterus to failure of one whole duct system to survive and grow, to leading to, say, a one-sided uterus, or what we call a unicornuate uterus. So if somebody has a miscarriage past 10 weeks with a heartbeat, or if they've had 3 of them, even the really early ones that we call biochemical pregnancies, where they have a positive urine pregnancy test, but then it goes back to negative, we will go ahead and do a pelvic ultrasound to look at the uterus, and then also look at the what's called a hysterosalpingogram, which is a test where you float liquid up into the uterine cavity, and you make sure that you don't see any septum in the uterine cavity or lesion in the uterine cavity like a large fibroid or a polyp, or scarring in the uterine cavity. So uterine scarring, or Asherman's syndrome, can be caused from having a miscarriage and then needing to have a D&C, or if you had a baby and you had a lot of hemorrhage, especially if the placenta penetrated too far into the uterus and the doctors are trying to stop your bleeding, they will have to do surgery to try to scrape that stuff out of there. And when they do, they may scar the uterine cavity. And then that can set the patient up for more miscarriages. So we want to look for that uterine scarring or Asherman syndrome. Fibroids are pretty rarely a cause of just miscarriage, but if you have, but it's estimated about 5% of recurrent miscarriage patients have uterine fibroids as a cause for the miscarriage. So we want to look for those as well. Miscarriage or birth defects of the uterine cavity, such as uterine septum, that's a wall that runs down the middle of the uterus. Though it's controversial whether taking out the septum, which we do from below with a telescope, is successful at improving pregnancy outcome. Most of the data so far says yes. There are 2 randomized trials that are going on right now, and neither one of them, unfortunately, has data yet. And they've been, a long time. One of them is like 10 years old now. But is not, reached a conclusion, or they don't have enough statistical power to really tell us. But Anyway, most of us will say that if you have a midline uterine septum that's, some people will say more than 10 millimeters in length or more than 30% of the whole length of the cavity, that should really be trimmed back. And that's kind of what I do. And what we usually will do is do that hysteroscopically, then put in a balloon stent to hold the walls apart so that the septum can't regrow. We also do the same thing for Asherman syndrome. You want to keep those scars from reforming. And then you want to, in both of those cases, give the patient a lot of estrogen, and I prefer natural progesterone to help speed the healing of the uterine cavity. After the septum has been removed, you can probably attempt to conceive right after you get another period. Some people have said 3 months, and same thing with the Asherman syndrome. Depends on, I kind of give it, depending on how bad it was. If there's a whole lot of scarring and I'm really worried that maybe we need a little more time to get that uterine lining blood flow back into those areas that were all kind of, where there's no blood flow in there, we may want to wait for, 2-3 months or more to let that area heal up. And anyway, also, chronic infection in the uterine cavity potentially can cause recurrent miscarriage. So we can look at that. There's relative progesterone deficiency, or what's called a luteal phase defect. So these are cases where the patient doesn't make enough progesterone to keep that uterine lining going well so that the embryo has enough chance to be able to implant. Those, most of the time, it seems to me that luteal phase defect patients manifest as spotting for a few days before they actually get a period. And in those cases, in the old days, we used to do endometrial biopsies, and we would do 3 of them if we needed to, and then it was best 2 out of 3 as to whether or not there was really a mismatch between where the patient was in her cycle and where the pathologist said that the uterine lining was. Nowadays, I just tend to give people 200 milligrams of vaginal progesterone twice a day, starting 2 days after ovulation, and then make sure that spotting doesn't happen. We have them use it for 14 days, then they will go off, or they'll check the pregnancy test if they're pregnant. We usually will have them use it through the whole first trimester, and then they can stop. Intramuscular progesterone is pretty painful. It can also be used, but most people will tolerate the vaginal progesterone well. But again, we do vaginal rather than doing it orally. When you go to oral, the progesterone has to go through the liver, and so it just, you need a lot more of it to have any effect. And unfortunately, using oral progesterone during the daytime is just really difficult because people will be really sleepy. So so we tend to do it vaginally twice a day. Also, there's other factors out there. There may be, you've probably heard me talk about the disordered uterine lining bacteria that can happen, that may be associated with uterine polyps and endometriosis as well. But a disordered endometrial cavity that's full of, like E. coli and Peptostreptococcus and Clostridium difficile probably is really not going to help embryos. I mean, what we want in that uterine cavity are lactobacilli, and lactobacilli are the good bacteria that live in the vagina. They also are the bacteria that you use to ferment vegetables and make sourdough bread, and they make acid as a byproduct of their metabolism, and they help drive bad bacteria out. So, there's a transcriptome or DNA fingerprint test that's going to be coming out hopefully sometime in the near future. But until that comes out, I would really recommend that you go hard on the kimchi and active culture sauerkraut to get those fermented vegetables into your gut so that you can get that good bacteria into the vagina and into the uterine cavity as well. As far as what else? Anyway, I have a question. Somebody says, what is the source of natural progesterone? Well, normally your ovary makes progesterone, and then the placenta makes progesterone by the gram as you get into pregnancy. When you make it in the laboratory, they usually will start with some kind of organic chemical that's pretty close. So they'll usually start with like a steroid precursor that's from a plant base, and then they'll kind of just run it through the steps to make the same progesterone that your body makes, but they're just doing it in a laboratory. And then we have a question: does your office recommend a hysteroscopy or endometrial receptivity study after 3 or more losses before the transfer? Yes, and yes. We're offering the endometrial receptivity test, or ERA, E-R-A, and you guys can look that up. It's the company that offers that is called iGenomics, IGENOMIX, and they have what they're looking for are 238 of these proteins that are made around the time of implantation, and you don't have to have all of them. They're made in a relative sequence, and so you can do a mock embryo transfer. And instead of transferring embryo, you do an endometrial biopsy. So you suction out a little bit of endometrial tissue, which is very soft and gel-like, and then you send that to the laboratory for testing. And then they will tell us a couple weeks later when the best time for transfer is. So there are a lot of people who have been found to have receptivity windows that are not where they're supposed to be. So normally the blastocyst or 200 cell embryo rolls into the uterine cavity about day 5 of embryonic life, which is about 120 hours after you start really making a lot of progesterone naturally, and then it implants. Well, if you don't have an endometrium that's receptive for implantation for another 2 days, well, things aren't going to happen very well. So either the embryo doesn't stick, or it sticks and then gets miscarried, because it can't really set up good placentation. And in those cases, we found that some of those people appear to be just kind of on the early cusp, either early or late, on the cusp of that really good implantation window. So we have found, yes, that transferring or doing the ERA testing is really helpful. But for a lot of people, they're doing it before we even have a failed transfer. And because patients are demanding that, because they're like, well, why would I want to waste an embryo? And especially for the patients with endometriosis, we tend to see they don't have typical receptivity compared to, as the 120-hour thing. So I have a question: if OB starts progesterone suppository once positive pregnancy test, should they be called to see about starting it with ovulation instead of waiting? Ooh, so if you have a luteal phase defect, certainly you should start the progesterone 2 days after ovulation, and because you really need that even before pregnancy. For our patients who just have a history of recurrent pregnancy loss and no history of a luteal phase defect, most of us will still go ahead and give supplemental progesterone, but it'll be just when they start when they get that positive pregnancy test. So we like them to have it on hand and then get started with it pretty quick. Now, in those cases, there was a randomized trial out of England from a few years ago that showed that in recurrent miscarriage patients, that supplemental progesterone, and these are patients who didn't have a luteal phase defect, that supplemental progesterone was of no benefit. Now, that being said, I still give it to everybody who's a recurrent pregnancy loss patient. It's pretty well tolerated. It's not very expensive. It's just messy. That's the only thing with it. And I think it gives us something to tell the patient to do. And when people have had recurrent miscarriages, they are so stressed out that if you can give them something, even if it's probably sort of like a little placebo effect, it can really, it may help. So I'm a big fan of that. The other thing is there was one randomized trial. Granted, it wasn't huge. It was from a long time ago, but it was from Sweden, or I want to say Sweden, and the authors were there's 2 names, Stray, Peterson, and they showed that having patients come in for weekly visits or weekly ultrasounds if they wanted them, once they'd had recurrent miscarriages, actually decreased the risk of miscarriage. And that may speak to that, addressing the whole stress part of things. So it may be comforting for patients to be able to see that ultrasound every week and see the baby, especially past certain milestones. Like if people have had miscarriages right at 7 weeks, which we see over and over again, a lot of the time being able to get them through that and get them get them that ultrasound that week, the next week, a lot of the time they'll actually feel better about it. Now, a lot of our insurers are not going to pay for those ultrasounds. So, I mean, I think that we as clinicians need to kind of address that and make that as affordable as possible. But anyway, there may be some benefit to that. Stress in general, has been shown to cause bad IVF outcome. There was one paper from years ago that showed that stress in IVF caused more biochemical or early miscarriage pregnancies. So, really complicated issue, but, we tend to want to really address that stress problem by having people get counseling if they need it, try to mitigate their work stress as much as they can, try to get into a good place before they ever get to an embryo transfer or trying to get pregnant with like superovulation with insemination. So I think those are really important things. Another question, when there have been three, those same question as far as the ERA testing, sorry. Then other testing. There's other stuff that we want to do as well. So there's a small subset of people out there who have problem, no uterine lining birth defects, no problems with progesterone insufficiency, but they have a problem with blood clotting. So the blood clotting issue, if people have, there's really three tests we're looking at that have been shown to be associated with recurrent pregnancy loss. One is called the lupus anticoagulant. And if you have that, doesn't mean you're going to get lupus, but it was associated with lupus patients a long time ago. Cardiolipin, antibodies for IgG and IgM, and beta-2 glycoprotein antibodies for IgG and IgM. So those, along with then doing a genetic test called the karyotype to look at both the man and the woman's genetic factors, have been found to be helpful for diagnosing recurrent pregnancy loss. Now, if you have one of those problems with coagulation, then usually we will have those patients take 81 milligram aspirin and then heparin, or a fractionated heparin called Lovenox, through the pregnancy, switching over to regular heparin at the very end. And that has been shown to be able to take care of those problems, which oddly enough, it's not that they're bleeding themselves too much, like if they get cut, but they are more likely to form clots behind the placenta, which then can choke off nutrient delivery to the baby. So, but there's a whole bunch of other tests out there that are currently being investigated, and some of them I think are going to have a lot of merit. There's a natural killer cell immunoglobulin-like receptor test, or KIR test, that I think that in the future will probably be shown to be very helpful for trying to determine people's risk of recurrent miscarriages. Some of the autoimmune testing that people will do, or giving people transfusions of different, like husband white cells or whatever, I think that is so unsupported scientifically right now that it's really hard to get behind that. Certainly the insurers are not convinced of that data, because they won't pay for any of it. So and some of the tests are really super expensive, like $3,000-$4,000, and there's a little bit of physician conflict with some of those things, because the people ordering those tests a lot of the time are the people benefiting from them financially, which you don't want. You don't want doctors benefiting from ordering lab tests or prescribing medicine. So some of that gets kind of sketchy out there. And then the question, what can be done to prevent the repeated pregnancy losses? Well, certainly you want to correct any physical defect you got, like the scarring or the fibroids or whatever, or progesterone insufficiency, or uterine cavity infection. If there really is an infection going on, then treat that, get that under control. And then certainly supplemental progesterone, I think, is worthwhile. Now, some people will just go ahead and start taking aspirin, but I would not, unless you've got a definitive cause for that. The whole aspirin thing is really out there, and there may be more harm than good with that. Aspirin increases bleeding in most people, and Who knows? That really may not be good. There was one trial of IVF, a big trial in Argentina years ago, that showed that just of women who are trying to get pregnant, that with IVF, that the pregnancy rates were a little bit higher in the group that used aspirin, or significantly higher. But overall, even those pregnancy rates were not super great. And the rest of the world, there were 3 other groups that tried to replicate that study, and they never found any difference. And the thought is now that it's probably just the high meat consumption that Argentinians have, the high red meat, because beef is a staple there. And, if you're eating beef every day or 2 or 3 times a day, then you probably have a lot more inflammation going on in the body, and the aspirin may be helping to control that. But the whole point there is, don't have a lot of inflammation in your body. Quit eating a bunch of red meat. Don't eat a lot of saturated animal fat. Eat more fish. Don't eat junk food. Don't smoke, don't drink, don't smoke pot. All these things are big factors in things. Also, as far as hormonal evaluation, we really like to make sure that people don't have thyroid disease. Severe thyroid disease will definitely, interfere with good pregnancy outcome. Even mild thyroid dysfunction, we try to tend to get ahead of that, although the data to support that is not there yet. But I certainly think if your thyroid stimulating hormone is above the normal level, then you really should probably be taking supplemental thyroid hormone. Whether or not routine antithyroid antibody testing is warranted in cases like this is still, again, a little bit sketchy as well. And then polycystic ovary syndrome patients, in the literature for them, untreated polycystic ovary syndrome patients there was one study I saw that it was like 70% miscarriage rate. So clearly we want to get control of polycystic ovary syndrome and get that higher insulin production and higher inflammation diet under control so that we can really lower that risk of miscarriages and get better embryo quality as well. So what else? Somebody had asked a question, what are your thoughts on rest after transfer? Well, I think that the current consensus is that there is really no benefit to bed rest after transfer. Certainly, I'm old enough that, we were in training. If you had an aneverted uterus or uterus that was tilted forward, we would, do your transfer and make you sit around for a while for 4 hours with, not being able to get up. If your uterus was tilted backwards, lots of times we, did your embryo transfer with your bottom up in the air, crazy stuff, and then staying down for all this time. Again, no benefit whatsoever to any of that. So I tell my people, don't go out and work out that day. I mean, we use diazepam to relax the uterus for transfer, and so I think people should just go home and take a nap after transfer. But they could go for a walk later on that evening. I think that's reasonable. There is, likewise, we used to tell people don't have intercourse until your pregnancy test. That's crazy. There's, again, no benefit for that. I tell people not to have intercourse for 2 days following the transfer, and then to go ahead and have intercourse because it actually may help with getting pregnant. You never know with some of that. There's all these transforming growth factors that are in seminal plasma that make their way up into the endometrial cavity and find a home there, and they may be there for a reason. So that actually may be helpful. And if you think about it, with natural conception, people aren't having long abstinence periods, and people will have orgasms and have contraction of the uterus with orgasm as well. And it seems to be perfectly fine. Anyway, sorry, I'm going to try to look. I'm missing this one. I'm going to try to see this one question a little bit better. Okay, yeah, and somebody says, what are your thoughts on keeping TSH below 2.5? And I that's where I go with it. But again, there's no data to support that. But I like to keep the TSH between about 1 and 2.5 because historically it's just been easier when people do get pregnant. You don't see their TSHs rocket out to like 5, like we used to see a lot of the time. So I'm a big fan of keeping those TSHs down. We usually just use levothyroxine, but if the TSH is bouncing around in somebody, I usually will default to the brand name Synthroid. And then there's a question: what are your thoughts about using alternative medicine such as acupuncture pre and post transfer, and possibly to help maintain pregnancy once the embryo implants to lower the risk of miscarriage? Well, there's just not data on that. There was one randomized trial of IVF with acupuncture, and it didn't show any result. It actually showed a worse result in the acupuncture group, but it was a horrible design. And the reason it was horrible design was it was in Los Angeles. They made the people drive to a separate acupuncture center across town and then drive back for transfer. That's nuts. I mean, you can't do that. That's super stressful inducing. You know, the whole point of the acupuncture is to make people pretty chill. So I'm always a big fan of if you like acupuncture, go ahead and do it. If it relaxes you, I think it's nice. It's probably, you know, kind of doing some of the same stuff that that moderate exercise will do for people. When patients want to do acupuncture, we like to have the acupuncturist come into the office and do the acupuncture, you know, right before the transfer. And then they, you know, will do that for, you know, half hour, pull the needles. You know, my experience has been that, you know, you get a good acupuncturist, it relaxes them a lot. It probably decreases catecholamine production. And so it boosts urine output. So a lot of those patients need to urinate a lot afterwards. So we'll let them, you know, empty out a little bit before transfer, and then, you know, go ahead and do transfer. And then usually they just go home. But I think if you want to do it again after transfer, if the acupuncturist, you know, thinks that that's a benefit, you could try that too. Doing acupuncture later in pregnancy, I don't know if there's any data. I mean, most of our patients typically do not, but I don't know that there would be any harm to that. So anyway, if anybody has any other questions about recurrent pregnancy loss, you can ask them now. Otherwise, if you have other questions down the road, you know, send them in and we'll try to answer them on another Hutchison's Huddle. And anyway, and again, shout outs to my coworkers, to Karina and Bakame for making these things happen, and to my co-collaborators on many of the other huddles. So feel free to kind of take a look at those, because there's a lot of good patient information in there. And a shout out to John Dote at the It's Greek to Me restaurant, who brought in our lunch today, because it was fantabulous, really good Greek restaurant on the northwest side of Tucson. So if you ever want to do that. Oh, I do have a question. What do you recommend? Do you recommend metformin for patients with PCOS? I do. I do, because it punishes you. It spanks you hard if you eat carbs and sugar. And that's the whole point. You shouldn't be eating that stuff. It is really bad for you, and it increases inflammation in your body. Now, the crazy thing is, you know, it's a drug that's safe in pregnancy, but recently there's been some data saying that it's associated with childhood obesity. So the current recommendation is for you to stop when you're pregnant. I still tell my patients to take it through the first trimester. The thing that's irritating about that whole thing associated with childhood obesity is polycystic ovary syndrome patients are an imprinted population. They're gonna have a higher risk of type 2 diabetes and obesity. What do you think their kids are gonna have? A higher risk of type 2 diabetes and obesity. So I don't know the right answer with it, but historically, you know, metformin has helped a lot of our patients to ovulate, but it really mainly is through that sort of negative reinforcement of, if I'm taking my metformin and then somebody brings me in donuts, if I eat them, I'm getting diarrhea for like hours. So people just don't eat that stuff, and then they don't have all the metabolic response to it that interferes with ovulation, and they don't get the inflammation, and they don't get the bad gut bacteria, because all those bad junky foods hurt your good gut flora. Again, eat that kimchi and sauerkraut every single day. A couple mouthfuls of that. Eat your fatty fish and stay away from junk food. Another test of the uterine lining to determine the best receptivity. Is it a true mock cycle, progesterone in oil, shots and all? And your answer is yes, it is. It is a nasty little protocol. But we still use in embryo transfers now, because the Shady Grove group back on the East Coast did a really good randomized trial of vaginal versus vaginal plus IM. And the biochemical rates were a lot higher in the vaginal only group. So we're still doing we've gone back to doing the intramuscular injections, either in large doses, 100 milligrams, or with 50 IM and 200 twice a day. But with the ERA protocols now, we're doing mostly just progesterone, 100 milligrams. Interestingly, once you get that positive pregnancy test, you can probably discontinue the injectable progesterone altogether and just go to more vaginal. But you may not need it at all. But certainly 2 pregnancy tests intramuscular is really important. So to make for commonality, or to make the ERA test valid, we do it exactly the same way as when we're going to do an embryo transfer. And then a patient asked, do you recommend being on metformin if not trying to conceive but have PCOS? And that is, I would just give that to the patient. I mean, I heard that some of these Silicon Valley billionaires are now taking metformin because they want to live, forever, to control our lives, and they're using it as a life extension drug. And as a life extension drug, I suppose it would be there because it would punish you if you eat bad food, and then you live longer. So, so I don't know. I think that if you can control your diet and you don't need the metformin, then that's what I would do. It's just one less thing to have to take. And certainly if you got into a car crash, for example, with it, and they needed to give you IV contrast, if you already had kidney damage, there'd be some issues, and potentially some issues with metabolic acidosis in a trauma situation like that as well. So if you don't have to use a drug, don't use it. Except if you're remotely in the market for getting pregnant, definitely take your prenatal vitamins, and we have everybody take vitamin D 2,000 international units a day, and then the coenzyme Q10 in the medium chain triglyceride form, 100 milligrams twice a day. But I don't know. You can if you want to. Same thing with inositol. I like the Myo to dechironiositol mixture, the 40-to-1 one, and it may be better than metformin. But whether you should be taking it if you're not trying to get pregnant is hard to know. Certainly, if you're not trying to get pregnant, you got polycystic ovary syndrome. If you've ever had any excess hair growth or high androgen levels, I would recommend that you use oral contraceptive pills if you can, if you don't have migraine with aura, and you can find a good one that you tolerate well. But anyway, so thank you so much for tuning in, and we'll have other ones in the future for you for other patient education. And have a great night.